Okay, welcome to Spine Conference. Today's topic will be vertebral hemangioma, and I like to do cases that I've seen because they're real people, and you never forget somebody you've met, like when you're a doctor, like cases you've seen. So, as always, if you have any questions, just interrupt me. So, sorry you can't see the top, but the history is a 67-year-old man whose chief complaint was low back pain and bilateral sciatica, and he had pain in his lower back and his posterior thighs to his knees and not past that. And he's had symptoms. He had symptoms for months, for 6, 7 months, and he saw another spine surgeon. The other spine surgeon retired, and then he followed up with me 6 months later. But by the time he saw me, his pain was gone. But he just wanted to know what it was. Hey, Patty, good morning. His past medical history is significant for depression, sleep apnea, gastric ulcer, right partial knee replacement, left rotator cuff repair, cardiac stents in 2009, angioplasty 2011, coronary heart disease. His right eye was resected for carcinoma in 2014, colon surgery. I'm not sure what the colon surgery was. I think diverticulitis, hypertension, hyperglycemia, TIA in 2017. So he has peripheral vascular disease. His medications are fluoxetine, rosuvastatin, topral, omeprazole, vitamin E, C, coenzyme Q, aspirin. So any questions about the history? He took a leave for about 5 feet 10 inches, 242 pounds. So he does have a calcified aorta, which goes along with his coronary artery disease and TIA. So he has vascular disease. Just from high cholesterol and hypertension, he's a non-smoker. Yeah, so he definitely is a vasculopath. And on exam, he's stiff. He's stiff on all range of motion. So this X-ray on the AP view, what do you see, Aaron? What do you see on the X-rays? Tell everybody. Yeah, L4. So L4, there's an obvious abnormality within the vertebral body, and corduroy. Maybe you could say it's corduroy, and we're going to go over that. The way I would describe it is, it seems like there may be some striations in the vertebral body, or definitely some irregularity in the bone of the L4 vertebral body, seen on both AP and lateral view. The body itself, the square, looks about the same, don't you think? There's no fracture, there's no deformity, there's no enlargement of the bone. So, and also, anything else about the spine, just in general?
Is that one a little suspect?
Maybe. It's calcium. Alan already said calcium in the aorta, so he has peripheral vascular disease. The disc height at L4-L5 is decreased, I think, and maybe at L5-S1 mildly decreased. And anteriorly, at both L4-L5, L5-S1, there's some osteophytes you can see around the disc spaces. So these are kind of like minor changes, but in this patient, it's significant. And then on flexion extension views, no significant abnormal motion, but also not a lot of motion either. So if you had a ballerina and had her flex extend, she would go, like probably 180 degrees. And this 67-year-old man has very limitation of motion of his lumbar spine. But as far as 67-year-old man, it's probably within the realm of normal.
Does he have osteoporosis?
Maybe his bones are washed out a little bit. Some osteoporosis, osteopenia. The other interesting thing is the posterior portion of the. Aaron, can you point it out to everybody? The posterior portion of the L4, L5 vertebral body is calcified. The disc is calcified. Can you point it out? See how it's calcified? I mean, I don't know how important that is in this relevant case. So what are people's thoughts at this point? Low back pain, sciatica, and his pain's gone. He took a leave for 6 weeks, and his pain is gone now. But he made the appointment, and he wanted to know what's wrong with his back. He decided just to follow up with the appointment. And we see people like that all the time. They're asymptomatic, and yet they went through such intense suffering while they were symptomatic. They still want to see the specialist to know what was that happened to me. So any questions or comments? Degenerative disc disease, probably what happened, and then it's very typical. You take nonsteroidals for 6 weeks, and the inflammation's out of the disc, and people are okay. They're asymptomatic. They're still stiff. They still have a problem, but yet they can go about their lives with good, good quality of life, and they don't need anything else. But my concern was, is this Paget's disease? Because I thought it was Paget's. I thought the trabeculi were irregular, and if it's Paget's disease, I want to know about it because the patient should know. He should have his alkaline phosphatase followed, and just to make sure, his calcium, see his calcium, make sure it doesn't become more symptomatic.
Well, I think read recently a paper on hemangioma of the
Yeah,
vertebrae.
yeah.
It looked very similar to this picture.
It does. It does look like a hemangioma. It really does.
Yeah.
And it could be a hemangioma, but we're gonna get into that. What he is. We're gonna get this. So. You can have polyostotic Paget's disease, but for it to be like next to the vertebral body, it's very unusual. Usually, the presentation's like pelvis and spine or something like that, but they're usually not next to each other. And it's not too common. Polyostotic Paget's is not too common. Okay, so this is just I wanted to rule out Paget's disease. This is an X-ray of Paget's. Coarse trabeculi, obscuring of the junction of the cortical cancellous border. That's what happens in Paget's. Irregular bone formation, enlargement of the bone can get bigger. The only thing that makes a bone bigger is Paget's, if you want to know a little secret. The bones can become deformed. And also, we're not talking about Paget's today, but since I discussed it, we should just go one more thing. Paget's is an uncoupling of bone formation and bone destruction. So our bodies are the bones are constantly being eaten up and made bigger, eaten up and made bigger. And this remodeling process is what gives us our strength of our bones. So if you took a X-ray of not Joe Flacco, because he didn't have a good year, but say Terrell Suggs' forearm, it's really big, strong bone. I mean, massive bone because of all the force that's put on his forearm, and it just the bone keeps remodeling with respect to the forces that are put across it. So in Paget's, that's uncoupled. So it just eats too much bone down, and it lays down too much bone. It's not organized. Okay. So here's the MRI of the not Paget's, but the previous patient. So on the left is T2 weighted images. On the right is fat suppression images. And what are people's thoughts? Any thoughts of the L4 vertebral body? You can see the degenerative disc disease, right? The discs are bulging backwards a little bit at both L4, L5, L5S1, and slightly abnormal. Yeah, slightly abnormal. And on the fat suppression images, yeah, but is on the fat suppression images? Is it dramatically different from the other bones? Very similar, right? Slight. I mean, it's not like a big bright spot, put it that way. So it doesn't really change too much. And then how about on the pre-gadolinium and post-gadolinium? So if this was a cancer, it would light up. Is there a big difference, or what are your thoughts? Anybody? Slight abnormality, but not in the color isn't the color pretty much the same? It's just the it looks like the striations are different. So here's an axial cut. So it's definitely different. The L4 vertebral body is definitely different from the pedicles, right? But on the left, maybe the process is going into the left pedicle. Would you say? Maybe. And the cortex, the posterior cortex of the vertebral body is okay, but the whole vertebral body is involved. Does this expand past the cortex, like into the retroperitoneal space? No. Doesn't look like it. Although on the left there looks something weird. Never saw that up until right now. See that? Should point out where the psoas is. The left psoas, the other one, right there. See that? Here, let me point it out. Actually, I never saw this, but this is a little suspicious. Um, so, okay. And here's L5. That's what it should look like to give you guys an idea. So here's the T1 weighted images, and maybe it goes into the left pedicle, and maybe it does expand there into the psoas a little bit, soft tissue. Kind of interesting, right? So let's look at the CAT scan. What does the vertebral body look like? Can anybody, Alan, you said it. What does the L4 vertebral body look like? How would you describe that? Because we have to use words. Speckled or polka dot, right? Polka dot. And those are vertical trabeculi going up and down. The cortex looks okay, posterior cortex looks okay, and all the cortices look okay. There's no fractures, there's no abnormalities, but definitely the vertebral body is normal. It does not look like this process is going into the left pedicle. See how it stops? Yeah, I'm showing it stops. But the MRI did have increased signal, which was interesting. And then the L5, this is what it should look like. This is the L5 body, which is normal. So here's the coronal section, and you can see the L405 disc. Aaron, point out the L405 disc has a vacuum sign phenomena, and that's consistent with degenerative disc disease. So this man does have degenerative disc disease. How would you describe the L4 vertebral body? Is it anybody? What do you think? Is it very regular? Is it irregular? Does it look like a jailhouse vertebra, or slightly regular? Like, what are people's thoughts? So it's not totally regular, right? It's a little bit irregular, but you do see vertical striations going up and down. Okay, and he does have degenerative disc disease. L5S1 has some minimal reticulocesis, and the posterior annulus. The posterior annulus is calcified, and the the disc is calcified at L4 or 5 as well. And so, I mean, those are very typical for lumbar degenerative disc disease. Okay, so what is everyone's diagnosis? Vertebral hemangioma, right? Because that's what the lecture is on. And now the hemangioma of the vertebra, like Alan says, can be polka dot, or people describe the CAT scan as jail bar or corduroy cloth. The trabeculi are coarsened. The vertical trabeculi are large and regular, and the horizontal ones are resorbed, because we have trabeculi in all planes. But in this case, the hemangioma, the tumor, goes into the body and sort of expands, and what's left in the vertebral body is basically the bare minimum that we need so that there's no fracture, which is vertical. Because if it wasn't for the vertical, it would smash. So there's not as many horizontal forces, but there's a lot of vertical forces. So that's why the body just maintains these like columns sort of in the vertebral body to keep the strength of the bone. And some people call it a honeycomb pattern. The vertebral body usually has increased signal in both T1 and T2. Only 1% of these people become asymptomatic, and it's probably even less. And there's different types of hemangiomas. There's typical, there's atypical, and there's aggressive. And at the end of the lecture today, I'm going to poll everybody and ask them what they think this man was, because we looked at it carefully, and we're going to understand. I think it's less.
Symptomatic.
Oh, symptomatic. Yeah, it's an area. I meant to say symptomatic. Yeah. So, and hemangiomas are very, very common in the spine, and very, very few of them become symptomatic. We see them all the time. So some people call it a honeycomb pattern, and the honeycomb describes the regularity of the vertical striations of the trabeculi going up and down. And when you look at the axial cut, you see the axial cut on the CT there. You see how the dots, it's like very regular dots of the vertical striation, honeycomb pattern. Or like David said, corduroy. So if you look at the coronal section or the sagittal section, it's the up and down vertebrae look like either corduroy, like a corduroy cloth, or jail bar. It's like these up and down. Or polka dots on the axial cut, it looks like polka dots. And those are the vertical striations, and they're usually very regular like that. And basically, this is the Parthenon in Nashville. It's basically these columns. Like the strongest way to hold an architectural structure is a column. And it's basically the body is creating columns because that's the best way to hold weight. And and it has a minimal amount of bone, so it maximizes the strength of the vertebral body. So Nashville, Nashville has a complete replica of the Parthenon. It's beautiful, and inside there's a statue of Athena. It's incredible. It's an old building. It was built for the World's Fair. I think it was a long time ago, maybe 50s or something. So it's a little bit in disrepair, but it still works. And there's a museum inside. And the only reason I went there is because my in-laws live there. But if you ever go to Nashville, it's a great thing to visit. It's really beautiful because people from Nashville, they thought of themselves as like the Renaissance of the South. You know, it's like all the culture and intellectual activity of the South is centered in Nashville. And that's why they built the Parthenon, because they're like Athens. So this are going to be a whole bunch of facts, and I'm sorry that I'm going to go through it quickly. But so the incidence in autopsy studies is 10 to 12%, but I think it's a lot higher. I mean, I think it's how many do you think? I mean, I see them all the time, so probably like 25%. If you do an MRI of the whole spine, very, very common. It's most common in 40-year-olds, fifth decade of life, but anybody can get hemangiomas. Children can get them, pregnant women can get them. It's more women than men, 2 men for every 3 women. So you can treat these things if they become symptomatic with vertebroplasty, radiotherapy, ethanol. We'll get into that. The best way to diagnose this is the CAT scan, because the MRI scan, it may look like a tumor. You see this is a hemangioma. You don't know what that is, but the CAT scan is the polka dots, jailhouse corduroy pattern, sort of sine qua non hemangioma. But these hemangiomas can be active, like they can be aggressive, and they can fracture, they can bleed, they can extend into the soft tissues. The aggressive ones are more vascular than fat, and when they're symptomatic, half of them are axial, and a little less than half have neurological compression, especially if there's a fracture. And the ones that fracture are usually young adults, and usually people who have it in the thoracic spine. And the atypical, so the hemangiomas go from typical hemangiomas to atypical hemangiomas to aggressive. And the aggressive ones are the ones that cause symptoms, like are expanding through the cortex, cause fractures, go into soft tissues, have epidural extension. A bone scan is not helpful in these people. It's sort of like equivocal. So if you cut it open and look at it, it's a soft, well-demarcated, dark red mass. That's what hemangioma looks like. It's basically filled with blood. If you put these under the microscope, they're thin-walled blood vessels with a single layer of flat endothelial cells, the loose edematous stroma, and the vessels permeate through the bone marrow and trabeculi. And there's fat, there's adipocytes, vessels, and interstitial edema. So if there's a lot of fat, those are the benign ones. If there are a lot of blood vessels, those are the more aggressive ones. And there's 2 types. There's the cavernous ones, which have big areas, big blood vessel-like masses, and there's the smaller ones. There's the capillary ones, which are small vascular channels. So those are the 2 different types. So the more vascular it is, the more aggressive the tumor it can be. So this is just, I didn't give you this, but if anybody wants this, I'll send them the article. It's just a 10-year follow-up of 6 symptomatic vertebral hemangiomas treated in Israel. And they had 10-year follow-up, and 6 cases, 4 out of the 6 had embolizations, 2 were just vertebroplasty. And these are, I know this is a busy slide, but these are all the treatments. Everyone did well long-term, but the one take-home, which I circled, is the biopsy caused massive bleeding. So in my mind, I think if you're going to approach these things surgically, you approach them like a renal cell, which is a very, very vascular tumor. And you've got to take all the precautions you do with renal cell, which is preoperative embolization. So see if there's a huge vessel feeding it and embolize it. I think the best, if it's a fracture and there's no soft tissue involvement, the best treatment is a kyphoplasty or vertebroplasty. This is what vertebroplasty and kyphoplasty was originally designed for, was for a bloody tumor in the spine. And it just fills it up, so it basically kills the tumor and gives it immediate support, and it's percutaneous. So it's a great treatment, I think, if you have like a fracture due to a hemangioma. The only problem is that the cement can go into the spinal canal if the posterior cortex is destroyed. So you have to be careful. You have to watch it carefully. Um, so that's a treatment. Another treatment is ethanol. I've never done this, but the ethanol, if you inject it into the tumor, destroys the endothelium, shrinks the tumor, causes thrombosis, but it can recur after ethanol. And radiotherapy is another treatment. I don't have any experience with this, but the negatives are it can cause malignant transformation. It can give pain relief, and it's best for if you have a subtotal resection of an aggressive one, you do post-op radiation. So I didn't send this to you guys, but if you want it, please feel free to email me and I'll send it to you. It's just the use of fat suppression to see if it's an aggressive tumor. And this study found that the aggressive hemangiomas, so basically the ones you have to worry about, have a very high T2 fat T2 signal of T2 fat saturation. So in other words, they're very vascular. So remember the one that we looked at? It didn't really have a high signal on the fat saturation. It looked like the rest of the fat. But you see the top right slide, it does light up. So it has low fat content. So if it's low fat content, it means it's very vascular. So those are the aggressive tumors that can expand into the thecal sac or soft tissues. So this is just a graph of the signal on T2 fat saturation. The non-aggressive ones were not bright, but the aggressive ones were very bright. So this is a way, by MRI, you can tell if it's going to be aggressive. So this is just the same thing. It's just the aggressive ones have a higher signal. So you want to know if something's aggressive, because if it's aggressive, it's going to cause a problem. So this is just from an article in 1986. The aggressive ones tend to have the whole body involved. They extend into the neural arch. The cortex is expanded. It goes into the soft tissue. It has an irregular honeycomb pattern, and it's usually the thoracic ones. So the aggressive ones are poorly defined. They expand the cortex. They can have lysis. The pedicle can be eroded. The bone can collapse. There's ballooning of the bone sometimes. If there's a paraspinal mass, if it extends past the bone, the cortex adjacent to it is intact. So there's no real fracture, it kind of expands. And the body height's maintained. So this is an atypical one. You can see on the right, the trabeculi are irregular. And the middle one, you see the axial cuts. There are the polka dots and the vertical striation, but it's irregular and it's mixed. It's heterogeneous. It's not homogeneous. So this is typical of a more aggressive hemangioma. So this is the article that we all read, which is a great article. And this is just a case of an aggressive T8 lesion in a 42-year-old woman. And you can see it's expanding posteriorly. It's expanding into the soft tissues. You can see on either side. The cortex is intact. It's irregular. The differential diagnosis in these cases is multiple myeloma, lymphoma, metastasis, plasmacytoma, which is a solitary myeloma process. Rarely is epithelial hemangioendothelioma. That's the path that you see there, and a chordoma. So I think if you have an atypical, if anybody has questions, interrupt me. If you have an atypical hemangioma, you have to rule out metastasis. So I think all these people need to get a CAT scan of the chest, abdomen, pelvis, and a bone scan and blood work to see if they have a mono gamma globulin spike, which is myeloma. So they need all these, and you may need a biopsy. But if you biopsy it, it's probably best with CT guided biopsy, and people have to be ready. It may bleed a lot, so it's like you have to approach it like renal cell biopsy. So the plasmacytoma doesn't look like aggressive hemangioma. It has, you see how that plasmacytoma here looks like a brain a little bit with sulci? They call it a mini brain appearance. So plasmacytomas look like that. They don't look like, they don't have the polka dot striation appearance. And this last slide is found in the article, is just all the different signs of typical, atypical, and aggressive. And I think of it as a spectrum from benign to aggressive, and atypical is kind of halfway. So let's do a poll. What do we think our patient is? Is it typical? Is it atypical, or is it aggressive? What are anyone's thoughts? Yeah, I think so too. Why do you think it's atypical? Right, but no, but it goes a little bit into the pedicle, right? And it's irregular. It's not straight up and down bars. Remember, it was slightly irregular. You want to go back and look at it?
Didn't we see the disc protruding a little bit?
Yeah.
That would explain his autism.
Yeah, that's his low back pain. But you see, it's kind of irregular. And then on the MRI, it is I think it's expanding there to the left a little bit. Yeah. So he has a little bit of an atypical one. But he's asymptomatic, which is good. And although he is polka dots a little bit on the left, it looks a little irregular, doesn't it? It doesn't look like polka dots on the left of the body. So I think he has slight atypia.
I may have missed this, but they usually involve only one vertebral.
They can be more than one.
An isolated one or several.
It's both. It can very often it's many areas. The small ones, the big ones, I think is just isolated.
You don't see them in all the bones. Elsewhere in the bone.
That's interesting. Let me think about that. I don't think they're that common. No. It may be because there's so much marrow in the body, in the vertebral bodies. Unlike, there's very high, but you don't see them in the proximal tibia, I don't think. And where there's another big metaphyseal area, or the humerus, huh? I don't think they're that common, but I'm not sure. But just from my experience, I haven't seen that many of them. Anybody else? Any comments or?
Can we look at some original picture?
Yeah.
About L1, wasn't that looking related?
Well, see, the cascade is normal. So I see what you're saying, but it's okay. I see what you're saying. It may be slightly, but we have all the other studies which are normal. So.
Can I see those references quickly?
Yeah. Which one?
That one.
This one? Journal of. I'll send it to you. Just email me to remind me. I'll send everything to you. Just email me to remind me. So that's all I have today. This one? Okay. So yeah, aggressive one. So he is a little bit irregular honeycomb. He may have a slight soft tissue mass. He's not thoracic. His cortex is not expanded. It's not into the neural arch, but the whole body is involved. So he does have some. He's kind of like he's atypical, I think. These are all just aggressive characteristics. So what would you all do with him? What would you all recommend? A big surgery? Asymptomatic. He says, I feel fine. So I watch him. Like just everything in medicine, just watch him. So I said, come back in 6 months or 12 months. I want to get another CAT scan and see if it got worse. So just observation. And he may just go his whole life with this thing and not bother him. Hopefully that's what I hope. Okay, so that's all I have today. So any other questions about vertebral hemangiomas? Is a very common diagnosis, and I think it's good to understand common problems and know when they're a problem, so we have to act on.
I never knew that.
Not really.
They're very, very common.
And then they're going to be patients they're going to be patients who have more than one thing wrong with them. They're going to have a vertebral hemangioma, but they're going to have another problem.
Yeah.
So that's in the mix too.
Yeah. It's good to understand these things, and you can deal with them better when you take care of patients and know the problem ones. Unfortunately, this man, he had a big one, so I was worried about it. I didn't know what it was. That's why I did all these studies, so I can understand it better, so I can treat him better.
Is misdiagnosis common?
No.
These lesions, or It appears to be a vertebral hemangioma, but it's malignant and all of that.
I don't know. Radiologists, they're pretty astute. So I think they know when something's a myeloma and when it's not. But I don't know. I haven't missed many. I haven't had any missed diagnoses. But I think about it a lot, huh?
But you also order
Yeah.
Test
I want to be sure. I mean, I don't want to miss a cancer. Because if you miss a cancer and it progresses, then it's terrible for the patient. So I usually I'm on the side of caution as far as workup and an evaluation. So I get the blood work and the whole workup just to make sure it's not cancer. Because if it's cancer, it has to be treated, and you need a biopsy, and you need to do what's right. So any other questions about vertebral hemangioma? Now everybody's an expert. All right, thanks for coming.